Welcome to Talat Yaqoob, who's our collaborator for today. A little bit about Talat before we go ahead and start. So Talat is an independent social researcher, consultant and campaigner. She has worked across the third sector in areas including mental health stigma, women's labour market, and inequality and access to education. Talat's work focuses on anti-racism, gender equality and intersectionality in policy and practice. She's an award-winning writer and campaigner, and she's the co-chair of the First Minister's National Advisory Council on Women and Girls. Talat, we're delighted that you're here with us today. The floor is yours, and I'm here to help in any way I can. Thank you very much.
Thank you so much. Thank you for the invitation to be here and also for that warm welcome. You might have to help me straight away because the share button has gone grey again. So if you can just Lindsay, if you can just pop that back on, and then I'll be able to share with you all. Like I said, a huge thank you for the invitation to come and speak with you all today. The purpose is to give some insight into what is a term that is increasingly used across Scottish policy making, across service delivery, and also working in and around communities, but often a word that's used before it is fully understood. So I will share my screen now. It should be working fine. So you should be able to see that now. So in today's session, we're going to be talking about what does intersectionality actually mean and what is it in practice. I'll be doing this for hopefully no more than 40 minutes, and then we'll be able to come to yourselves for questions, discussions, examples you might want to share. So whilst we are doing this presentation, and it will be a bit probably too much of my talking at the beginning, and please do think about any points of clarification you would want to ask about, any examples from your work practice, or any experiences in relation to this that you would like to share. I would be really welcome that in the last kind of 15-20 minutes of this. So I'm going to give you some examples of where the notion of intersectionality comes into play around the work that we're doing. Intersectionality is fundamentally about understanding that we don't exist in silos. We don't have single issue lives, in the words of Audre Lorde. Instead, there are overlapping and compounding experiences that are often ignored. I'm going to give you some examples of this from both health, social care, and social work spaces. So the first picture, which is at the top, and you've got somebody, checking heart rate and blood pressure there, is an issue called that is colloquially called Mrs. BB syndrome, which you might have heard about. What Mrs. BB syndrome refers to, and the name is given Mrs. BB because it's specifically about older South Asian migrant women. BB is a common surname that is on official documentation, although BB with older South Asian women is actually a term of endearment and respect rather than an actual surname. But during partition, most documentation was lost or never created in the first place. So when passports, birth certificates were required, they used the terms and the names that were most commonly used as opposed to their official names.
Talat, I'm really, really sorry to interrupt. I think the slides are not moving, so we cannot see the image just now.
Thank you. You should be able to see that now. Thank you so much. I really appreciate that, and apologies for that delay. So at the top, you will see Mrs. BB syndrome, as I was talking about that. And it's older South Asian women who have had discriminatory experiences in primary healthcare settings. And this is evidence that has been gathered to indicate that experiences related to coronary heart disease, experiences related to mental health, mental ill health, have gone either wrongly diagnosed or not diagnosed at all because of a combination of ethnicity, migration status, age, gender, and English as a second language, all coming together to create consequences that are significant health consequences for older South Asian migrant women. The reason that has the overlapping experiences of them being women, of their ethnicity and race, of English as a second language, of their age. The same is not found of migrant South Asian men, for example. So that's what we mean by the compounding experiences and inequalities and intersecting inequalities that create different and worse outcomes. In the second picture, next to which it says O'Hara, it is in relation to ethnicity plus the experience of having learning disabilities. O'Hara is a researcher that since 2003, so for a significant amount of time, has talked about the need for cultural competence in social work and social care related visits. And what she talks about there is that time is often not given to understanding the compounding inequalities of having a learning disability and being from a Black, Asian, or minority ethnic background. And as a consequence, there have been what communities feel are wrong or hasty decisions made about independent living or living support. And at the bottom, COVID-19, you might have heard the phrase same sea but different boat. So whilst we talked about it being a same experience for everybody, it was not. There was a disproportionately worse health outcomes according to class, according to disability, according to race, ethnicity, and migration status. And if one or more of these overlapped, there were significantly worse outcomes, particularly for migrant individuals whose second language was English and who were working in precarious contracts. I had the privilege of being able to keep myself safe whilst working from home. Precarious work in retail, in support out in healthcare settings were much more likely to be of Black, Asian, and minority ethnic background. So we saw a higher level of communities of colour experiencing worse health outcomes during the pandemic. I give these examples to be able to showcase some of what happens when those intersecting inequalities overlap to create worse outcomes for individuals. So this is where intersectionality comes in. None of us exist in silos. I am a Muslim woman of colour. I do not engage with any service, any policy area, even any people, whilst choosing which of those things to be at any time, and very much not choosing how systems respond to me. I am all of those things at the same time. And those of you on this call are, of course, multiples of this. You're dependent on what age you are, disability that you might have, the gender or sex you might be, the sexuality you might be. Those things may overlap to create worse outcomes because it is systems of oppression and societal, historic, and institutionalized inequality that can overlap to create worse outcomes. That's what intersectionality is asking us to analyze, not see ourselves as individual areas of inequalities, but that actually for most people, there will be overlaps, which means there are specific outcomes and specific delivery that needs to change and be enabled to create a fairer Scotland, but regardless, fairer society. So where the term came from. The term was created by the framework of and analysis of intersectionality was created by a civil rights activist, academic, lawyer, Kimberlé Crenshaw in 1989. Now, the reason I highlight two things here, the fact that it's 1989 and really intersectionality has come into kind of the lexicon of systems change, lived experience, and policymaking only in the last 6 to 8 years. But the concept was in her first academic published paper in 1989. The second thing I want to point out is its origins are from the intelligence, evidence gathering, and experiences of Black women in America. And it's important that when we take an intersectional approach, that it is embedded in competent practice that is both feminist and anti-racist. What she talked about there was in her 1989 paper was about employment rights. She was specifically talking about the experience of unfair pay of Black women in America, in the pharmaceutical industry and in the car and retail industry. And what she was talking about was that Black women, despite taking on employment tribunals and cases about fair pay, their experiences and their legal cases were dismissed. And in particular, it was dismissed on two grounds, either on the basis of race, because they could point to an evidence that Black men were paid higher sums, or it was dismissed on the basis of sex, where they were able to look at white women who were paid higher or fairer sums. They were unable to take to court and get justice based on both race and sex. And that is an intersecting inequality and oppression that they faced that was dismissed because of the way in which race and sex were interpreted as being two separate areas of inequality. She also felt that the civil rights movement didn't think enough about women, and the feminist movement did not consider racism effectively enough. And I believe it still has a long way to go. The concept has, of course, existed long before, as the experiences of compounding inequalities have existed from the very start of society. But the application of intersectionality is growing. As I said, in the kind of last 6 to 8 years, we've heard about it a lot more. And of course, we've had many reactionary responses to it. But actually, we're seeing it being embedded more across healthcare and social care and social workspaces. Here are just a few examples. There's work being taken forward to ensure that the Maori community in New Zealand, particularly those who are older or disabled, are better responded to in social work delivery in New Zealand. This includes working with the community to be able to identify the right questions to ask that might be different from generic surveying and questioning with social work visits. There's work in London, which includes the lived experience to tackle multiple health inequalities, particularly those that are faced by migrants, Black, Asian, minority ethnic individuals, those whose second language is English, and the overlapping of that with disability and disability discrimination. And a third example is the very clear impact of the higher rates of death and significant health issues that are experienced by Black women during labour and through their maternal health support. So there's significant work going on that focuses on Black women in America and how to improve and reduce negative health outcomes during their labour experience. So that's just a few examples of where intersectionality is being applied in how we deliver improved healthcare outcomes and improved social care support. What's really important to say, and this is what we see far too much of in Scotland, is that it's not a new word for diversity. So if you were to go anywhere, and you can help me out here because I have to say it too often, and if somebody says we need more intersectionality in a room, that doesn't make sense. It's not a new word for diversity. What you can say is we require more experiences of intersecting inequalities in the room, and we need to take intersectional analysis in the room. It's not a new word for diversity, because actually having diverse people in a room doesn't mean an intersectional analysis unless those diverse people are A, have the expertise to apply an intersectional analysis, and B, are given the permission and safety to talk about their overlapping and intersecting experiences of inequality. So you can do me a favour by saying that in as many rooms as possible so I don't have to. So it also doesn't work if it's diluted. So I call it diluted intersectionality. There's other terms for it. Christopherson in 2021 refers to it as generic intersectionality. And that's where we go full circle. So we talk about not having people in silos and thinking about the specific overlapping inequalities that some communities face. But sometimes that is interpreted wrongly, as that means everyone experiences different inequalities. So we revert back to sameness or generic delivery. That's the opposite of what intersectionality is asking you to do. It's asking you to be more specific, more deliberative to improve health outcomes for a wider range of people. So rather than sameness, it's asking for specificity. It's not an easy word to say, actually. I'm really glad I managed to get that out my mouth the first time around. So some key challenges when it comes to intersectionality. Whilst the term is being used a lot more in Scotland, there is not a coherent approach across Scotland's public institutions. And we are at risk of this being buzzword territory, where it's said, but it doesn't actually relate to people's lives or actually deliver any kind of substantive change. We have to move away from the buzzword territory and actually invest in capacity building, definitions, and understanding around this so we know how to apply it. One of the biggest issues is that intersectional and disaggregated data is very rarely made available. We are still very dependent on large data sets that do not ask questions about intersectionality, or small data sets that don't allow us to disaggregate based on, for example, race and gender, or race and class, race and disability discrimination, or class and gender, whatever it might be. Because we don't have enough information across the board, we continue to assess information and evidence in a siloed way, when what we need is more data that allows us to see the overlaps. We also have a tendency, as I already mentioned, a diluted one-size-fits-all approach. We require further investment in that data collection, but critically further investment in the space and the time and the opportunity for people to develop skills in this area. And we need to move away from siloed policy making, which is still what happens here. We respond to one protected characteristic at a time, forgetting that actually, if we do that, we tend to engage those people who already had some access to power, opportunity, and wealth. What's really important is intersectionality is not asking you to take an individualistic approach. It's not saying, what does this one person need? It's asking you to assess the overlaps of oppressive systems. So it's asking you to assess how systemic racism, systemic misogyny, systemic bigotry, systemic disableism or systemic disability discrimination, systemic homophobia, how do these things make sense as a system, not an individual response? Us as individuals will experience things in these overlaps, but it's not because we're not experiencing them because we're individuals. We're not the cause. The cause is historic, it's systemic, it's institutionalized. So the very purpose is to look at systems that need to be changed, not individuals that need to be changed. What we tend to find is that people will interpret intersectionality in a deficit model. So let's look at all these overlaps of this person who's a migrant, second language is English, is perhaps has a learning disability. How do we make them, how do we do something specific for them so that they fit into an unequal system better? No, intersectionality is about how does the system stop doing the inequality that prevents that person getting what they need. I'm going to give you an example of this. If we don't take an intersectional approach, sometimes policy that is created has an unknowing impact upon those who are furthest away from opportunity and wealth and power. You might have heard of something called no recourse to public funds. This is a particular label, a particular category on a visa. That means that many migrants come to the UK with, particularly those who are on worker visas, particularly those who are students, who will come to the UK and they will have on their visa no recourse to public funds. This is, of course, very important when we're talking about healthcare and social care in particular. What it means is that they cannot access what is a service, a support space, which is fully publicly funded. So the purpose of the policy, and this is what I talk about in terms of systems, an individual didn't cause this, the systems caused this. The purpose of the policy based in the reserved policy area of immigration, the purpose is to act as a deterrent towards immigration to the UK by certain groups. It's to prevent what they refer to as economic migrants and migration. And they want they want caps on migration and lower migration to the UK. But what is not thought about in that particular policy is the number of horrific outcomes that are caused by it. One is the knock-on effect specifically to women attempting to escape domestic abuse. If a migrant woman who's here has no recourse to public funds, it's very likely that she cannot access everything that she needs to be able to safely escape an abusive situation, particularly services that are publicly funded. So it has a disproportionate impact on women. Within that disproportionate impact on women, it will have a further disproportionate impact on women whose second language is English and are women of colour, and disabled women who are more likely to require specialist services that are fully publicly funded and are often already difficult to access. Now that has a knock-on effect on the groups that actually policy is attempting to support through anti-violence against women strategies and policy, gender equality policies. But without thinking about the knock-on effect of policy and the overlapping inequalities and systems, that actually we need to deliver better an intersectional approach. That would mean that these policies didn't have such a harrowing effect on women who need support the most, as one example. Why this matters, and in terms of the allyship work that was referred to at the beginning, this doesn't mean that I'm calling for there only to be one equalities network where everybody comes in. Absolutely not. There should be specialist spaces. But what it means is, for the illustration I have of a woman of colour here, the women's network needs to understand intersectionality and needs to respond to anti-racism better. The Black, Asian, Minority Ethnic Network needs to be able to respond to the experiences of women who are going to be in that space. The more of an intersectional approach that's needed, the more relevant the space becomes and welcoming the space becomes for those who might need it the most. Now, I can't cut myself in half and decide to go to both of these spaces. I might want to opt to go to one space, but I need all of me to be welcome in that space for it to make any real difference and be a genuine inclusive space for us to be able to function in and build better outcomes with. I'm going to give you an example. And I think somebody in the chat function there mentioned we've been talking about data for a very long time. You are absolutely right. I've been doing this work for far too many years, and I am exhausted by how much I have to talk about data, because if the issue has been pointed out, there's a conscious decision to not think it important enough to invest in. And I do believe that there is much more to be done here and accountability that's required within that. So to give you an example of what happens when we don't have disaggregated data, let's talk about the gender pay gap. So the gender pay gap in Scotland is around about 10.2%. And it's important that we highlight that. It's important that we look at that for the problems it creates. But when we talk about that, we're talking about overall the experiences of women in Scotland. Some of them will be working part-time, some of them will be working full-time. They also have caring responsibilities potentially. But that is a data set of 10% that looks at women as a homogenous group. If we were to drill down into that and talk about the data information that we have underneath it, and we were to think about the intersection of ethnicity as well as gender, we would find that the pay gap for Bangladeshi migrant women is 12.3% when compared to British-born white women. If we were to think about disabled women and not think about them only as women, but because they are also disabled, it jumps up to 19%. When we don't think about the information lost in general data, we encourage the experiences of intersectional oppression to be ignored. What we're looking to do is to highlight that in a way that is genuinely purposeful, so that we are able to use data to create better outcomes for people, whether that is economic outcomes, health outcomes, and of course, those two things being completely related to one another. So forgive me for a second whilst I give you a very long metaphor, an extended metaphor of a tree. So one of the things that I always ask people to consider is think about when you're designing a service, you're thinking about a policy, maybe you're funding a new project and you're seeking budgets for it. Think about an intersectional approach. If we were to look at it as a tree and we were to see the trunk and the bark as the status quo of power, the closer you are to that bark, the more likely you have access to some kind of historic, entrenched, rooted power, because you're closer to the base. This is most likely to be the case if you're white, middle class, university educated, non-disabled, straight and male. Now, that's where we talk about the 1% of people who have access to property, wealth, power, and political decision making. Often what we do when we pursue non-intersectional policy interventions, we might make some difference for people who are in the leaves that are closest to the bottom. It's what we refer to as the lowest hanging fruit. Now, we could reach them, and I'm glad that we reach them because those are people who are further away from the roots of power. But it means that we actively exclude those who are further away in the furthest away branches above this dotted line. When we don't take an intersectional approach and decide we're going to do something for one of these groups, where we decide, let's talk about women, or let's talk about disabled people, or let's talk about ethnicity and communities of colour, let's talk about migration, that's great, it's important, Let's talk about those things. But we might only reach the dotted line. When we take an intersectional approach, if we're designing something for disabled people, and we also think about the fact that they might be LGBT, they might be women, they might be migrants, their second language might be English, they might be working class on precarious work, close to the poverty line, or clearly already in poverty, which is more likely to happen for the groups that we want to engage with, then actually we should be designing from the top of the tree down. If we do that and we work from the furthest away branch, the consequence of that is active inclusion rather than designing from the lowest hanging fruit, which becomes active exclusion. So I'd really recommend that using this kind of metaphor of the furthest away branches, we think about, if we're talking about one protected characteristic, who is also in that protected characteristic that has multiple intersecting, compounding inequalities that they face, as well as being in that category. That's called active inclusion in design and production. A word, though, about lived experience and intersectionality. So, for example, one of the things that we talk about a lot is lived experience and co-production. And we're talking about this more and more in understanding who has power, who does not have power, understanding the hierarchy of power, and making sure that what we create is fit for purpose. Whether it's the creation of Social Security Scotland by the Scottish Government, for example, whether it is about projects within local authorities related to the delivery of a new social care provision, what will be happening as we go forward with potentially a national care service, there will be many opportunities where lived experience panels are engaged in this work. That's really important for intersectionality, because you're not just looking for diverse lived experience, you're looking for the lived experience of intersecting, overlapping inequalities, and giving people permission to be their full selves with that intersectionality analysis to be in the room. But what's really important is lived experience is not a one-off. Lived experience engagement is not about giving voice to, it is fundamentally about power redistribution. Because otherwise what we're doing is consultation. Lived experience expertise with an intersectional analysis is about handing over the power to make decisions, to do design and co-production with those who have lived experience of intersectionality and lived experience of intersecting inequalities. But what's really key is when we do that work is giving people who are on lived experience panels training, capacity building, support and time to build their knowledge around intersectionality so that they can bring their experiences forward and engage in the experiences of other people too. Taking an intersectional approach across health and social care provides an opportunity to build deeper relationships and, crucially, trust within those marginalised communities, because what intersectionality does is make their experiences more visible in the work they do. They see themselves reflected in the analysis that's happening, and that, as a consequence, builds trust that allows them to engage further and actually come forward when they might need support, when they might need advice, when they might need advocacy. So a few points on what does this mean in practical terms. So intersectionality and intersectional analysis and frameworks can be applied to all aspects of our work, but here's some examples that I wanted to talk through. So firstly, our internal culture. So recruitment practice in any area of work that we're in, taking an intersectional approach means that actually maybe we think about the fact that we're not just looking for employees to be, we want employees to be fairly paid, but we also need to think about the fact that actually they might have, they might also be carers. They might also have religious practices that we need to respond to. But rather than seeing these things in silos, it is about understanding that people might need the support across all of those things and might have the experience of multiple. It's particularly crucial when we talk about pay and promotion, going back to the experiences of Black women in employment tribunals and fair pay that was outlined by Kimberlé Crenshaw. And despite that being in 1989, I'd like to say that we're further ahead within the legal sector in being able to understand those overlapping experiences. I'm afraid we're not. It's about learning opportunities, making time for an intersectional analysis. It's also about decisions we make about what we are going to spend on. An intersectional analysis related to budget allocation also allows us to understand which communities are most underserved and who we are not prioritising. In community outreach, it helps us to build trust and relevance. And in particular, it allows us to do lived experience engagement that is purposeful because people see themselves and see their whole selves as being welcome in a space when you take an intersectional approach. In service delivery, intersectional approaches allow us to distribute information in a more meaningful way. So not simply, is this information available in a different language, but is this information available in a different language? And if women who don't speak English as a first language were needing this information, where do they go? Where would this information need to be for them? Maybe some people who do not speak English as a first language also has a disability. What does that mean for how they do sign language, for example, because it might not necessarily be BSL? And it's, again, the relevance of services to communities. Taking the experience of New Zealand in social care, social work with the Maori community, it allows us, an intersectional analysis allows us to ask the right questions in assessments and ask questions that people feel seen by, and you are then enabled to give them the right advice, support and advocacy that they require. And finally, in influencing policy, whether it's at an organisational level, local level or national level, national health and social care priorities, intersectionality allows us to evaluate whether who they work for, against, what are unintended consequences for some communities. And in things like responses to health crises, whether that's COVID or actually health crises and health inequalities, full stop, it prevents us from using policymaking in a siloed way and forces us to think about, in this category of communities, if we use a homogenous approach, what does that mean for who will be left behind, even when we have good intention with our delivery? So this is hopefully a bit of a whistle-stop tour of intersectionality, but what I wanted to leave you with is a little bit of a checklist that I think is really helpful in taking first steps to apply an intersectional analysis. So the first is disaggregated data available? And I remember this coming up in the chat. If not, why not? And how have you highlighted which information is not available and how this has consequences for our delivery of good work? Secondly, how have those with lived experience of intersecting inequalities been resourced and supported to develop, co-produce or co-design this work? How have they been enabled to share intersecting experiences rather than sharing what they think they've got permission for, which is what has always been asked, their experiences as a single siloed approach, as opposed to their intersecting inequalities? Going back to that metaphor and that diagram, have you developed this from the top of the tree down? And crucially, and this is always really telling, next time you read a report, write a funding overview, when you say or write 25% of people, 25% of women, 25% of disabled people, who within this group do you actually mean? And when you use a homogenization, who is it that might have worse outcomes that the general statistic ignores because they are a smaller group with worse outcomes within this wider group? If you read a report and it says 25% of women said X, the question to always ask is, what about disabled women? What about working class women, migrant women, women of colour? What does that mean for those who are perhaps lost in what seems like better data because their full experiences are not articulated? And finally, does your policy position, service delivery or project have direct or indirect negative consequences for those who experience compounding inequalities? How have you showcased this? How have you illustrated it? What evidence do you need that enables you to do that better? So I'm going to ask for this to stop being shared so that we have time to answer questions, have any chats, experiences or examples that you'd like to share with me. And it'd be great to see some faces as well, so it doesn't feel like I'm only talking to Michaela. So if anyone wants to do that, that would be great.
Thank you so much, Talat, for your perspective, sharing your wisdom with us. And from reading the comments and the reactions during the session, I could see a lot of what you said resonated with the experiences of our colleagues who are joining today. Thank you so much. And as you're thinking about questions that you might want to ask Talat, I have one, if that is okay. First of all, so many takeaways. I love how intersectionality is not a new buzzword for diversity. I love the tree example, the checklist, which is very practical. I'm thinking, especially in times of change, financial struggle, and uncertainty, which we are facing at the moment, how do we continue to challenge as leaders so people who are at the margins and communities who are experiencing structural violence are not being pushed to the margins again, if you like? So what gives us momentum? What should we pay attention to?
I think in terms of momentum for taking forward this work when it comes to different marginalised communities, I think within our organisations we always want to see examples. We want to be able to say, here is a case study, here is a piece of work that allows us to show the relevance of this work and then how to apply it. But the issue we find there is that quite often the evidence, the data, the casework doesn't exist, because a lot of intersectional delivery, a lot of analysis of this kind is happening within communities themselves who don't necessarily have the resources to put together the data, publish the data, put together the case study and actually put it out there. So sometimes this is happening, but it's not been registered, it's not been noted and published somewhere. There is more of that happening. And I try and share as much of that as possible. So using case studies is certainly a way to do that. But I think maintaining momentum is actually almost like a business case for intersectionality, because what we can do and the information we do have is the consequences, financial, health outcomes, the future of Scotland. We're able to showcase what are the consequences of not taking an intersectional approach, because the outcomes are worsening. So I think whilst we don't necessarily have enough case studies or data, what we can exemplify is what happens if we keep working the way that we are working. That data we definitely have. And I think that creates momentum for us being able to take this forward and make the business case to those who need to put the resources behind it.
Thank you. Thank you very much. And again, a few comments about the tree reference, and if we could share that, I will definitely share the slides, but anything else you could share, Talat, in terms of how we could use that work and the data to create more momentum with that. And again, you can put a question in the chat, you can raise your hand. Shumela, please come in.
Hi, thanks for that. It was really, really interesting. However, as the leader of a lived experience-led organisation, so for me, I have some concerns about us only focusing on those kind of protected characteristics that you mentioned throughout, because in regards to discrimination, there are some other huge key drivers that would fall into intersectionality for me: poverty, being care experienced, drug addiction and alcohol addiction of your parents or self. And I think that only focusing on those kind of protected characteristics that you mentioned, we really miss out a large part of our population. And as I say that as a mixed race person that works in a predominantly white community, where I see huge numbers of young white men, for example, who experience all of those things that I mentioned, but might not fall into kind of some of the areas that we might focus on, but are absolutely drivers of what then might come out of some of what you're saying, you know, some of that discrimination that then other people might experience. So yeah, just wondering if your work takes into account things like poverty, being care experienced, and other drivers within our communities that often are born out of things like trauma.
So one of the reasons why so if you look at the tree, I very purposefully, even though protected characteristics, although class isn't in that, I always talk about poverty and working class within the work that I'm doing, because protected characteristics do not reflect the extent of life experience. And so intersectionality as an analysis can and should go across different experiences that create discrimination, as opposed to taking the legal outline, because actually Kimberlé Crenshaw's very point was that the law was not serving this. So I think that, all of my work actually is embedded in 3 areas of work: racism, misogyny, and poverty. And it's those 3 areas. That's my specialism. That's what I work in. There's people who have very clear specialisms in, for example, experience of the care sector and the experience of being in care, and work around the promise, although perhaps more radical in some of those spaces. But I think that there's a significant amount of work going on in that area. But I want to be very clear that my expertise are on that 3. But a good intersectional application does not hold itself hostage to protected characteristics, in my view.
Thank you very much, Mela, for the challenge and the perspective, which is very, very welcome. Navid?
Thank you. And thanks, Talat, for a very thoughtful presentation. As you were talking, I work in the public health system. So many examples was coming to mind. Years ago, I used to work for the type 2 diabetes and weight management service, and the worst outcomes, health outcomes in relation to those kind of like health conditions was for ethnic minority women of older age. And kind of like putting that intersectional lens on it, I mean, it's very obvious why that was the case. For example, the services were only available in English, the diabetes education services, and post-COVID, they're only available online. Which kind of like think about those 2 kind of like restrictions on the service. We exclude a big chunk of our ethnic minority women of older age, and it's no surprise that the outcomes are much worse. And I think the other problem in the health system is that the services are very disjointed. The person is not seen as a whole. So you have a service, for cardiac diseases, for weight management, for type 2 diabetes, for all mental health and all that. And I think that also, because when you think about, for example, a lot of kind of like ethnic minority people who represent to some of the health services, they don't come with just one health condition. They might have a whole lot of kind of like different health conditions that require support. But again, the system doesn't look at it as a whole. So any views, any reflections on those couple of examples?
Yeah, I think it actually really relates to Shmela's point about holding ourselves bound to the protected characteristics, because actually in 2024, digital exclusion actually needs to become one of the things that we talk about in terms of an intersectional analysis, because what was found time and time again, particularly during the pandemic, is that actually data literacy, poverty, that meant that you didn't have access to that technology or were able to regularly purchase data, rurality, that prevented you from having access to broadband, which is a huge issue in Scotland still. So the data exclusion and digital exclusion is a big issue, because actually we're at the point now where life and access to services that protect us is not necessarily available without some digital access. So then it becomes a human rights issue. So from that perspective, I am not surprised at all that there is a very clear number of intersecting oppressions and inequalities that are happening there, because whilst there may be an effectiveness in pursuing digital health and social care support, there will be a huge proportion of society that do not have access to that and will not have access to that. So unless a competent intersectional approach is taken in the kind of rollout of that work, then there will be, you will exacerbate current inequalities even further, whilst giving it the notion of progress, because we're talking about digitization, right? So I think this is where an intersectional analysis becomes really, really important, because the notion of progress sometimes disguises intersecting inequalities that are happening underneath, because those groups are already more likely to be ignored. I hope that answers.
Thank you. That's brilliant. Thank you.
Thank you very much, Navid, for the question. And Julia, next.
Thank you so much for that. It's been really, really interesting. And I guess I was reflecting on what you're saying about momentum, and also on the fact that I feel like you were saying, we don't actually have good data in many cases anyway, let alone good disaggregated data. But I was wondering if there are any examples you have of anywhere, maybe outside of Scotland or in a different sector, that is doing this well, or that we could look to kind of like lead the way a bit.
Yes, to be honest, any kind of government, local authority, public institution meeting I go into and I talk about data, I can just feel the collective rolling of eyes, because I've said it so often now. I think where I am seeing this being done more and better is in some places in the third sector. And we can take examples of specific organisations that are, whether it's Inclusion Scotland, for example, that's working specifically on disability, but actually putting in the investment to making that specific on disability, but for everybody who has disability. There's a recent piece of work that's happened with the Scottish Women's Budget Group and Glasgow Disability Alliance to talk specifically about the cost of living crisis for disabled women. So we're seeing a lot more in terms of research, mostly lived experience led and partnered research, that is much more intersectional than what we're seeing in large data sets like the Scottish Household Survey. So I think there is really good examples across the equality sector within the third sector that I think we could learn more from. And I want to point out that Angela has made a very good point, and just in case I wasn't clear about that there is no underrepresented marginalised community that is at more risk of certain health outcomes. It's a consequence of systemic, institutionalised, historic inequality that means they will have worse health outcomes, means that they will have worse health, because the system is not producing a space in which they get to flourish in the same way other people do.
Thank you, Julia, and thank you for the response, Talat. There are a few comments in the chat, and there are good practice and suggestions there. So again, open, we have about 5 minutes left to see if there are any other questions. And again, the Ijoma, grateful for the suggestion there about the digital exclusion and how we can actually capture some data on that. Okay. Regarding EQIA.
Oh, so I have such strong feelings about EQIA. EQIA as a concept of creating a legal requirement to assess the extent to which you have interrogated and investigated the consequences for different marginalised groups is the intention is excellent. The delivery is really, really flawed. And what has happened is EQIAs have become a tick, yes, I've thought about this and everything is fine, as opposed to what is the evidence, what does it mean? Again, it is specific on protected characteristics. It's not asking you about class. It's not asking you about rurality. It's not asking you about addiction. So I do think EQIA needs to be more thoughtful about intersectionality, but I think there needs to be a real overhaul in how EQIA is done and how people have the capacity building and support to be able to actually do it well. Because right now there's not enough resource that allows you to take the time and consideration that's required for EQIA to be really genuinely beneficial. What ends up happening is that we tick the box, but there's lots of unintended consequences that we simply have not been given the resources, capacity and support to be able to really drill down and understand.
Thank you. Thank you very much for that. Okay, so I will just keep the space as I'm closing the session for any final questions, but I would like to say a big thank you to Talat for coming here today and sharing your wisdom, sharing your experience. And again, I will be putting the slides in the chat, but once we have edited the recording and removed all the IT gremlins and issues we had in the morning, but thank you so much for even not letting that phase you in terms of your presentation, which really, I found it very insightful.